Okay, you're going to go to Target. I want you to park as far away as possible. Didn't have time to go to the gym that day. That's okay. Get those extra steps in. Take a couple extra laps around the store. If you're at work, don't take the elevator. Take the stairway. Little things like that can actually, it's been shown, impact your cardiovascular outcomes.
Well, good afternoon. We got Dr. Peter O'Brien. So glad to have you today. A little bio on you. You ran cross country and track as a Division I athlete at Bucknell. Then you went on and continued your education at UVA and Wake Forest. And you're an interventional cardiologist at Centra, where you run and the director of the Centra Health's cath lab. You're also the co-founder of the Virginia Heart Attack Coalition. And it's not just cardiology that you started with later in life. Winner of the 10 miler, still avid runner, even tell me about the running. How did the running shape your entrance into cardiology?
Well, that's a great place to start. And thank you again for having me on. I've been running for 45 years, so I almost don't remember how it started. But I was kind of I guess for lack of a better way to put it, sort of a small, sickly kid. I had fairly severe asthma, and that really held me back somewhat in terms of activity. And somehow I just decided to go out for cross country and track in middle school because I felt like I needed to do something, and just fell in love with the sport. And had some success in high school, but really was fortunate enough to be recruited and coached by, he's passed away since, but a pretty legendary track and field coach, Arthur Goulden, who saw something, I don't know what, but really improved quite a bit in college. And, it's I think there was a commercial that most NCAA athletes are going to end up going pro in something else. And so, of course, didn't have the talent to be a professional runner, but it definitely shaped my work habits, my resiliency, delayed gratification, working towards a goal that's very far down the road, literally and figuratively. And ultimately, I think that influenced my pursuit of medicine, how I practice. And to this day now, I'm still a runner, a lot slower now, but big believer in exercise, very passionate. Spent a lot of time talking to my patients about exercise. And I really think running, walking, whatever you do is really a miracle drug that probably doesn't get enough attention.
And I imagine that going to see a cardiologist like you versus a 350-pound cardiologist that's got a cigarette dangling from his mouth is probably gives a little more a perspective.
Yeah, it's funny because I do have patients sometimes, and patients come to us from all different walks of life and different situations. So I try to encourage lifestyle change without being judgmental, because I don't know what they're going through. They may be working 2 jobs and they don't have time to go out for a run, or they're taking care of a family or an elderly family member. So I try to meet them where they are. But I do sometimes get that comment. I'll say, "Doc, you look pretty thin. What's your secret?" And what I tell them is, and I think sometimes people are, I know my patients can be, they're intimidated by exercise. They think that it's very binary. Either I'm at the gym for an hour, or I'm going to run the 10 miler, or I'm on the couch and afraid to get up and try something. The data and recent studies have shown that as little as 5 or 10 minutes of exercise, and we're talking walking up and down the driveway, a couple extra trips to the mailbox, as little as that quantity of exercise 3 days a week has been shown to reduce mortality. So I tell them, the American Heart Association says officially 20 to 30 minutes of moderate intensity exercise every day, or 150 minutes a week, that sort of thing. I said, that's the goal to aspire to, but every little bit helps. And I'll even translate into things like, okay, you're going to go to Target. I want you to park as far away as possible.
Okay, you're going to go to Target. I want you to park as far away as possible.
Get those extra steps in.
Didn't have time to go to the gym that day. That's okay. get
if
those
you're at
extra
work,
steps
don't take
in,
the
take
elevator,
a couple
take the
extra laps
stairway.
around the store.
Little
If
things
you're at
like
work,
that
don't take the
can
elevator,
actually,
take the stairway.
it's been shown impact
Little
your
things like that
cardiovascular
can
outcomes.
actually, it's
I
been
was
shown impact your
college athlete, a
cardiovascular
wrestler,
outcomes.
which is almost the night and day difference. One's aerobic, one's anaerobic. I remember reading Ken Cooper's book on aerobics back years ago. Now, how is the like a steady state cardio differentiate itself from like more like a hit workout or something that is high intensity?
Yes, that's a great question. It's funny, the wrestlers, we used to joke at Bucknell, the distance runners and the wrestlers were the last people to leave the locker room at night. So we know how hard you guys work too. So aerobic or cardio versus high intensity training. Now, I'm not an expert or an exercise physiologist, but there is some data to show that shorter bursts of intense activity have the same benefit. And for younger people, especially with limited time, busy schedules, that's often, whether they're incorporating short sprints into their run or they're on the bike or Peloton and they incorporate those bursts of activity, that can be very helpful. For a lot of my patients that have musculoskeletal problems, just getting up and walking is a big deal. It's maybe not as practical.
And it sounded like a short burst going a little further away. The Target parking lot that you referred to.
Right. Yeah. I mean, walking very briskly, jogging a little bit. The other thing that has come to light recently is, in terms of recommendations, is I'll tell my patients 2/3 cardio aerobic and 1/3 resistance training. That's especially important for people as they get older. We tend to lose muscle mass, and we either replace that with fat or nothing at all. And that's not good for us in terms of strength, stability, risk of falls, but also not good metabolically. Muscle is just a great thing metabolically. It knows how to handle glucose and insulin. It just makes us healthier. So I'll advise my patients, say try to get out 3-4 days a week. Those other days, whether you want to do lightweight training, push-ups, sit-ups, different people, again, with different joint problems, something may be practical or not. Try that.
Speaking of joint problems, it's all you're running. Have you had any? I'm getting my hip replaced.
Oh,
about
yeah.
2 months, and so
Yeah. I have to some degree. It is, I think, related, and we were talking before the show about, sometimes we do activity and exercise for health, and other times we do it for competitiveness. And a good part of my life, the running was really not about health. It was about going out and trying to run fast and beat people and be part of a team. And with that came a lot of pounding. So yeah, the knees are kind of creaking a little bit now, a little bit of a hip issue that I'm nursing as well. I went out this morning in Blackwater and thought, I'm going to run a little speed. Like, nope, going to run easy today. I'm not going to push my luck.
so you recognize some of those differences, and over time how we kind of decay a little bit.
We have,
And our arteries decay, our heart somewhat decay.
Yes, it does. A lot of, I mean, we can't fight time. I mean, there's certain cardiovascular changes that are going to happen. You see it in athletic performance, and you see it just in disease states. But some of what we accept as aging is actually deconditioning. We as species were not meant to be sitting in front of computers or at a desk or on a couch all day. We're supposed to be out doing whatever, chasing wild game and living off the land or farming, things like that. So we're meant to be active individuals. So some of what we think of as aging can be very much attenuated by exercise. I often say that my youngest 80 and 90-year-old patients are either farmers or they're avid, you see them at the Y every day. Those are the people that, as we say, age successfully.
And it's interesting you're talking about the how we grew up and whatnot. I asked some of my classes about comparing themselves now versus the King of France in the year 1500.
Yeah.
Everything you did required a lot of activity. Right. You couldn't just get heat. You couldn't just get light by flicking a switch. You couldn't just put something in a microwave. You had to spend lots of time and activity just to do the basic things.
Absolutely. No, I think I read, and I don't want to misquote this, but I read a study about the number of calories, say, the Amish consume in a day. And it's crazy. You or I would be 400 pounds if we ate that way. But because of what they do, the amount of physical activity every day, that's right for them.
And just basic things. They're not going to the gym, and they're not,
Right.
bench pressing 315.
Yeah.
They're
No Pelotons, So
yeah. Wow. And so now tell me about a little bit, as the director of the cath lab, the door to balloon.
yes, very important concept. And so, as probably most of your listeners and viewers know, I don't want to consult anybody's intelligence, but the heart is a muscle, and we call that myocardium. And that muscle is supplied with blood, oxygen, nutrients by small pipes called coronary arteries, which can, over a lifetime, develop blockages, develop plaque. Most of the time, that plaque is fairly inert. But what it can do sometimes is that plaque can fracture or rupture and form a clot, or what we call a thrombus. So a blockage can go from something you don't know you have or occasionally causes chest pain to a complete obstruction or occlusion of the artery. Whatever is downstream begins to die. So that cardiac muscle, that myocardium, starts to die. So we have a mantra in cardiology that time is muscle. And we've known this since the 1970s, that the longer that artery stays down, the more damage there's going to be. That introduces the practice, or is the theory behind the system, that we want to get the cardiac patient, the heart attack patient, from where they are to where we are as quickly as possible. So I'll often say in my state meetings or presentations, if grandma's having a heart attack, we want to get her from her living room to our cath lab table and get that artery open as quickly as we can. The terminology for that is something called either first medical contact to balloon. So that's when she encounters the healthcare system. That's usually an EMS provider laying hands on the patient until they're on our table, and we can thread a small balloon down the artery, open it up, and restore blood flow. That's FMC to balloon. If they're walking in the front door of the hospital, they drove themselves in, that's door to balloon. So basically the same idea, point A to point B as quickly as possible.
Several years ago, when we first got a grant in the city of Lynchburg, we got the 12 lead EKG.
Yes.
Where that was now in the ambulance, and then that could be transferred, the data, to the cath lab.
That was a revolution, and that did so much to improve that time and to save lives. We, around that time, when was that?
I think about 2008 or something like that.
That were
around there, just off the top of my head.
That would have been part of the efforts, because we did talk to the city and we talked to the Office of EMS. Matt Hanley, who's not here at Centra anymore, but an ER physician, we teamed up together. And I'll talk about VHAC in a little bit, but our statewide organization really committed itself to getting that equipment on ambulances across the state. When we started, I think a little more than half of the rigs of the ambulances in the state of Virginia had that equipment. By the time we were done, it was up to 99%. And it was a big team effort. It was talking to political leaders. It was talking to philanthropists, dealing with the Office of EMS, just kind of a real group effort. But that was probably the biggest, next to the Door to Balloon initiative, which I'll mention in a moment. That was probably the next great leap forward for heart attack care.
Well, yeah, I remember that because it was a novelty at the time.
Yeah.
I didn't know we never had it. I was the chairman of the finance committee. It came as a grant. We talked about it, debated it, and what's this technology, then started understanding it and how beneficial it can be.
Well, I appreciate and those efforts from, going back. I mean, that was really, I think, when our care got to the next level.
Nice. So now the Door to Balloon. So now the technology from the ambulance to the hospital or to the cath lab, now they're at the door. What are the normal numbers for that?
So the normal numbers, the guidelines set a goal of 90 minutes, either for FMC, first medical contact, or door to balloon. Because, if the patient comes via private vehicle, you don't have much control of what happened before that.
We don't have a grant for 12 lead EKGs in your car.
Yeah, right. Not yet. Yeah, not yet. I have a defibrillator in my van, but we don't have that yet. Basically, the goal is less than 90 minutes. At Centra, we had set a goal of 60 minutes.
So the 90 minutes would be, you had this problem that happened in your arteries.
Yeah.
Now you're wondering, hey, we need some care quickly rather than taking longer time as you described.
Yes, it's the time from So the 90 minutes refers to the time from first contact with the medical system. Now, in a perfect world, the symptom to balloon time, when a patient develops chest pain, which sadly, on average, they wait several hours to call, sometimes even longer. And that's part of our public education efforts. That's what we're trying to fix, getting people more aware of symptoms of a heart attack and the importance of calling 911. But be that as it may, that time of less than 90 minutes, we had set a goal here at Center of 60 minutes or less, because faster is better.
So 2/3 of the.
2/3 of that.
Okay.
We average somewhere between 38 and 43 minutes. And for FMC to balloon, and again, to put in perspective, a patient that, drives into parks at Lynchburg General and walks up to the door is a different circumstance than a patient in Nelson County or Charlotte Courthouse or Pittsylvania County. But even then, our median is about 70 to 74 minutes, which is pretty fast if the patient already lives an hour away. It's honestly, and I'll just say this again, it is a testament to our EMS providers, our emergency department, our nurses, our cath lab techs. These people are, they're amazing. They're amazing because of their expertise and commitment. But when you see one of these heart attacks taken care of, I always liken it to a NASCAR F1 pit crew. People have very defined roles. They go to work immediately, all for that patient, get that patient to the cath lab table so we can open that artery.
Yeah. And you mentioned about sometimes people will have symptoms for a while.
Yes.
Obviously we all grew up with the boy who cried wolf story, and we don't like to think, was this arthropathy? Is it, indigestion? Is it stress? Is it?
Right. It's funny, and you just hit on a sort of a human behavioral aspect to that, because I was on a committee with the American Heart Association, and they did a survey to see for the people that waited to call, what were the two big reasons. The two big reasons were money and embarrassment. They were worried about the cost, obviously, but embarrassed. They didn't want to get to the hospital and find out, you called, the ambulance came up to your house at 2 a.m., all the neighbors were watching you, it was just reflux or whatever. We try to when I talk to patients, I tell them, look at the flip side. It's so much worse for you to have sat on that heart attack. You don't know. If you have those symptoms, you can't diagnose yourself. You did the right thing. But honestly, most of the patients that call, I shouldn't say most, because chest pain can come from a lot of different causes. But we do have patients that was their intuition. They made that fateful decision to call quickly and really had a much better outcome.
Yeah. That's just be a tough thing to do. So the door to blue time is about half of the average. It sounds like, or actually less than half of the goal of 90 minutes. And so you're the head of the cath lab. So obviously, as you credit your team and all those that are involved, that it sounds like a well-oiled machine in NASCAR doesn't happen just because the one guy that's oiling it does require leadership.
Right. Yeah. I mean, I think what we've learned over the years. So I was able to stand on the shoulders of giants early on. I got to Lynchburg in 2001, and Mike Valentine, Carl Moore, Tom Nygaard, and Dan Carey, a couple of years before that, had committed to a door-to-balloon process. Now, this is an interesting kind of bit of history, because at the time in the 90s, nobody considered doing what they were doing. For instance, if the emergency department received a heart attack, you've got an experienced ER doctor looking at it saying, this is a heart attack, call the cath lab. Cardiologist would say, no, I have to come see the patient and bless this first. So as we say, handing the keys of the cath lab over to the ER, that wasn't really happening in most places. That one maneuver saved about 20 or 30 minutes right there. So they took the radical steps early on to say, we know time is muscle. We've known that since the 1970s. Why is this not happening faster? What are the simple things? What are the non-rocket science things we can do to make this faster? And that was one of them. They actually presented an abstract at a meeting and were laughed at, literally. So lo and behold, about 6-7 years later, Yale University starts looking across the world, trying to find these hospitals, these pockets where this was being done well. And they picked 11 hospitals international, and Lynchburg General was one of them. And I'll never forget being on a call with Yale, and And they said, we have two questions for you. Number one, how are you doing this so fast? And number two, where the heck is Lynchburg? Which, we thought was kind of amusing and telling. So basically, they then took those strategies, what was working, what was not working. They put together kind of a policy or sort of a program called the Door to Balloon Initiative with the American College of Cardiology. And fast forward 20 years, what was heresy back then is kind of gospel now. Of course you do these things. This is what we do. So much credit to those early, pioneers that said, this sounds nuts, but we're going to try this.
And so many things are like that, aren't they?
Oh yeah.
I mean, so many things in the whole life. It's like it takes outsiders to look at innovation and change, and that's never worked. That airplane will never fly. This doesn't work. Nobody will ever beat the 4-minute mile. I mean, all of those things are out there and laughed to scorn until somebody actually does it.
Yep. And somebody has a vision. Somebody articulates that vision, and you mentioned leadership. Somebody assembles the team, gets people to buy into that and say, this is what we're going to do.
Wow. So with lots of your work, which we'll get to in a minute on prevention. So as you're seeing patients, there's the care that they need to do. You do some tests. What are some of the tests that you do at first to assess what kind of direction you need to go?
So for a patient that is presenting with unstable symptoms, we're worried that they may be having a heart attack, is a different kind of patient than, say, you come to see us in the office because last week you had chest pain and we need to work on that further. So we'll take that more acute or unstable patient first. The primary tests that we do, or what we base our decision-making on, are basically that 12-lead EKG. And
So that's for heart attacks.
For heart
What
attacks.
if we go to a normal patient?
Okay, for a normal patient, good question. It depends on how they present. So cardiology is a little different in medical decision-making, say, than other fields of medicine, and I'll explain. So basically, and this sounds facetious, if a patient comes to you and says, Doc, am I pregnant? You run a test, you're pregnant, you're not pregnant, right? Or there are some other conditions. You run a simple blood test, you say, yep, you have this disorder, you don't have this disorder. We do some of that with testing with cardiovascular disease, but a good bit of it is based on what we call our pre-test probability. What is our clinical intuition? What sort of symptoms are the patients presenting with? What is their family history? What are their risk factors? Chest pain can be typical. It can, be just what the textbook tells you. It can also be atypical, and that's especially true of the elderly. But let's take your average middle-aged male or female that comes in with very classic symptoms, say they're diabetic, they're a smoker, things of that sort. You basically have, in general, kind of two buckets. One of them is stress testing, which allows you to get information about not only how does their heart behave, what does the EKG look like, what is the pictures we take of the heart, the imaging look like, but also how far can they go on the treadmill, how does their blood pressure behave, how do they look symptomatically. The other bucket, or the other, which is a more recent development, is what's called the coronary CT, or the coronary CAT scan. The coronary CAT scan, generally younger patients, and I apologize, I'm getting too far down the weeds here, but for younger patients with less calcium in their arteries, will often just go straight to what's called the CTA imaging. For older patients where the imaging may not be quite as good, we'll do stress testing. But I guess the take-home message is we have a variety of non-invasive tests that we can do. The other thing we do is we address risk factors. What's your blood pressure? What's your weight? How active are you? What's your cholesterol? What other diseases do you have that may modify this?
How about a coronary calcium score?
So coronary calcium scoring, there's a little bit of debate and controversy in that area in terms of nobody debates the value of it, but just what patient populations to apply it to. I like coronary calcium, especially if I have a patient that is a bit on the fence as to whether they want to take additional medications. So for instance, I have a patient come in and they are basically being screened. It's primary prevention. They're feeling good, but their wife wanted them to come get checked, or their boss said, "Hey, we're going to get these physicals."
Happened with me, so we'll try this personally.
Smart woman, so good for her. What coronary calcium does is it shows you calcification of the coronary arteries. Most plaque, not all, but most plaque develops a little bit of calcification, and that's what the scan can pick up. So if you see coronary calcium, it tells you you have plaque. It doesn't necessarily tell you how bad that plaque is. So if you see plaque, that's often a powerful motivator for that patient. They're like, I didn't want to take pills. I didn't want to take a statin. I wasn't as worried about my blood pressure as you were, doc, but now you're telling me I have coronary atherosclerosis. I guess I better get on this. A calcium score of 0 is reassuring. It's not 100%. There are cases where you can still have plaque. But that is a primary prevention screening test that, in talking to your doctor, may be beneficial in some cases.
And so with a high number, that then takes you down another path that says, hey, how is this plaque?
Right. So higher implies more risk. I personally, and I think the data would back this up, I don't routinely go to stress testing or catheterization for a high calcium score if that patient's otherwise doing well. And by doing well, I mean not having symptoms and are active enough to have gotten symptoms. They're out working, they mow the lawn, they exercise a little bit, they feel fine. But I do double down on the primary preventive therapies.
So primary preventive therapies such as?
Yes. So primary prevention, first and foremost, because I think it doesn't get emphasized enough, diet and exercise. By exercise, we talked about the AHA recommendations. Diet, a lot of information about diet out there. I try not to get too fancy with my patients. The Mediterranean diet is a good one. And it's basically not as exotic as it sounds. It's a lot of whole foods, whole grains, green leafy vegetables, nuts, olive oil, fish. All those things have been shown to be beneficial. There is data for plant-based diets. I tell patients, in Central Virginia, telling everybody to be a vegan is probably not going to fly. So I tell them, well, try to consume meat and dairy in moderation, and try to avoid processed foods as much as you can. So that's exercise, diet. Now, statins. Statins are...
Let's keep on the diet for a little bit first. So there's with the diet, there's obviously lots of different, debates and whatnot. And especially when somebody has seen what has been stated before, whoever it came from, how eggs are terrible. Well, eggs are great. Well, eggs are no yolk. And they've gone back and forth on things. And so lots of people are left kind of like, hey, we got to do what the Church of Berea did. They were counted worthy because they studied themselves and they didn't just believe what they heard, but they dug a little bit.
That's a great point. And this is part of the frustration, not only for patients, but for providers. Number one, diet is difficult to study because it's very multifactorial. I can give you drug A or a placebo and check back in a year, and that's pretty cut and dried, a randomized trial. Harder to do that with diet. It's harder to regulate exactly what you're eating and compare it to a different group. It's also turns out there are confounding variables, not to get too sort of statistically in the weeds. For instance, patients that eat healthy tend not to smoke, tend to wear their seatbelts, tend to get regular doctor checkups. So that can be difficult to sort out. I would say, in a way, we've made diet sometimes too complicated. I think a lot of
Back to the Amish, kind of like what you said.
Right.
You're not having those processed foods. So you're not just hitting the microwave and the plastics or whatever the things are.
Yeah.
You're actually picking your tomatoes off of the vine, or you're slaughtering the cow and
I think there are elements of processed foods that we don't even fully understand. I think the epidemic of obesity, something's going on that we haven't identified.
I'm big, but when there's a 20-year-old girl that's twice my size, it's like, how in the world can that happen?
And I think Dr. Josh Alley, one of our bariatric surgeons, gives a wonderful talk on obesity and has really changed a lot of our minds. Not that we were, judgmental, but you can't help but think, gosh, just get out and exercise. Don't eat as much. So there's some of that, but in large part, it's not that simple. And this is one of my own personal observations. I've noticed that just in the last 10 or 20 years, you will see parents or families where one generation is thin and appears healthy and fit, and the kids are obese. And I'm thinking that can't all be socioeconomic factors. That can't all be, these are kids that are active. And I'm far from an expert in this area. Dr. Alley can talk more articulately about this, but I have to think that, sure, maybe there's a lot less activity than there used to be, and that's definitely the case. But I do wonder if there are hormonal changes, if there are chemicals or things in the food supply that we just don't have a full grasp of.
Yeah.
But again, speaking off the record, purely theoretical, but it's an interesting area.
And I remember talking to I can't remember his name, but the other one that's with Dr. Alley.
Yeah.
And I asked him something. I said, hey, what do you think about a carnivore diet on a short-term basis? And I was surprised when he said, I'm fine with it for a long-term basis.
Yeah.
Because you're going with more, you're primarily getting rid of all the processed foods.
Yeah, I have had patients have success with basically eliminating carbohydrates for part of the week or part of the day, intermittent fasting, and the data's a little mixed there. And again, I probably shouldn't get too deep in that because there are people that know a lot more about this than I do. But my own practice experience is that the other thing I tell them too is you're not going to lose it overnight. Let's make simple changes. I told you to park further away at Target. So now what I want you to do is I want you to, maybe go to a low carbohydrate bread or give up a dessert at noon and have a little extra at night, what have you.
And they feel better too.
Absolutely. They always do.
The inflammation, the different things. I mean, it's yes. I remember when I was an athlete, I read this book, Eat to Win. It was nothing about carbohydrates and pastas, and I needed lots of that. And I was doing that. Well, it was fine maybe when I was young, but I kept that diet as I got old, and it's like, yeah. After you have a big, gorge out at the Kings Island buffet, you take a nap for 2 hours, and you wake up hungry.
Right. You just don't feel as good.
Yeah. So with that, as you're seeing your patients, it's obviously very difficult to get. It's a lot more difficult for somebody to change their world by diet and exercise. Maybe easier to, take a pill, I guess. And so with that, that's where I guess statins have their place. Talk to me about statins.
Yes. So I'm a big believer in statins. I take 80 milligrams of atorvastatin myself, maximum dose, and have done fine with it. Statins are
Describe for me the which one? The atorvastatin?
atorvastatin.
Okay.
So basically what statins do is they decrease the amount of cholesterol that we produce in our livers. And they are a great adjunct in the right patients. Not everybody needs one. This is where I think a conversation with your healthcare provider really is important.
So you're a big runner, you're thin, and you're taking is that fairly high dose?
Oh, yes, it was considered a high dose, but most people now are on 40 or 80.
Okay.
For personal reasons, my father had a heart attack and had already run 9 marathons. So bad family history. I had a very high LDL, low density lipoprotein. Even when I was training for a marathon, I was running 120 miles a week. That's about as much exercise as most people will ever achieve.
Just in a year.
Yeah, well, I know. Couldn't do that in a week. But, and even then my cholesterol was still high. Exercise is actually very, very healthy, but it won't necessarily decrease cholesterol in a lot of patients. It's kind of a different mechanism. So anyway, basically statins lower LDL, and there's a direct linear correlation between your LDL level and how much plaque and what cardiac events occur. So there's that. They also have other effects, beneficial effects on the plaque themselves. They almost have an anti-inflammatory effect. So what we have seen is, and I'll take patients, the way to think about this too is there's primary prevention. So you go to the doctor, nothing bad's happened yet, but you're worried or maybe you have risk factors. Then there's secondary prevention. Secondary prevention is we know you have plaque. You were in with a heart attack last week, year before you had a stroke, that sort of thing. Those are different scenarios. For secondary prevention, it's a no-brainer. A lot of the things we do, aspirin, statins, all that.
So the 81 milligram aspirin is
So for secondary prevention, for most patients,
risk of bleeding or something.
Yeah. So aspirin's an interesting story. And we used to be much more liberal on how we recommended aspirin. And that we'll talk about the primary prevention patients. Say you're a healthy 40-year-old comes in, doc, should I take an aspirin? Sure, it helps prevent heart attacks. We have backed away from that because there is a concomitant risk of bleeding. Now, there still are going to be a subset of patients, primary prevention, no documented cardiovascular disease, where aspirin still may be beneficial. But we are less aggressive in recommending that. To get back to the statins, secondary prevention, you're already seeing a cardiologist. Again, no brainer. Primary prevention, that's when you want to have a conversation with your healthcare provider. There are actually risk calculators, predictive scores to tell you roughly what's my risk of having something happen, stroke or heart attack in the next decade, risk calculators. They can use those. Just having a conversation with a patient. You know, I heard there's one other podcast from theheart.org, and the guy that runs that describes people as maximizers or minimizers. Some people will do whatever it takes to reduce risk. Other people don't want to take medications if they can help it. So that just points up the fact that we all have a different approach. Again, you have to kind of meet the patient where they are. You know, what do they consider to be a burden? What do they worry about? What do they don't worry about? So, but anyway, statins have been around since the 1980s, heavily studied. What we know about statins are, in certain patient subsets, the patients with documented disease, they can reduce the risk of heart attack, stroke, or dying by up to 30+%. And that's huge bang for your buck. The downsides, potentially, about 1 to 3% of people will get muscle pain. Usually that you stop or reduce the dose, switch to a different agent, it goes away. In terms of serious muscle breakdown that puts you in the hospital, that's about 0.1%. There was a scare about risk of dementia or cognitive decline that was not borne out. Actually, in some cases, statins may reduce that if they're stroke-related, vascular dementia. Liver disease, I don't think they even check liver function tests in Europe. They're not as litigious there, but I have not seen, occasionally you'll see some abnormalities in the blood tests. I've not seen the case. Not saying it doesn't happen, but it's extremely rare that you'll have actual quote-unquote liver damage. So I think the problem that we've gotten into is with the internet and then the rise of social media. That has been good and bad for medical care. It's been good because it's democratized information. It's actually made my job easier. I can look things up a lot faster than I could at the UVA Medical Library when I was a student. I can now just whip my phone out, get the latest study. It allows my patients to come in informed. And I don't mind when patients come in and say, hey, I looked into this, what do you think? No problem at all. The problem is that it's unfiltered. So you don't necessarily know if what you're reading, what the study methodology was, or even what the incentives of the author were. You'll see a lot of the articles, quote unquote, that are published about a certain drug. It turns out that person is actually trying to market a supplement to have you take that instead of the medication. So I'm not saying that problems don't occur. They definitely occur. The analogy I make is it's a bit like a seatbelt. You know, are there cases where a seatbelt caused a serious or fatal injury? Sure. But any cop's going to tell you, buckle up when you go out there, because your chances of surviving that car crash are much, much higher.
Well, I was with the city for like 20 years in city council. I remember we had an expert consultant come in that said that he was hired by the city staff. He came in and his job was to give us objective data that said, should you go from one-way traffic to two-way traffic downtown? And he had a resume, 24 years experience. He did this all across the country. And so as he's making the presentation, I asked him a simple question. I said, hey, and I touted his resume. I read it back to him, all of these things that you've done. Now, how many times had you ever recommended, instead of what you're recommending today, going from one-way to two-way, recommended going from two-way to one-way?
Yeah.
He paused and scratched his head and said, never.
Yeah.
Because the city staff, they hire the consultant with the objective of saying, here's what we want you to say.
Yeah.
Now say it. Is there any that, and obviously pharmaceuticals, they're in the business of, they want their drugs to, but I also understand capitalism. I mean,
Right.
if something isn't working, you got to change something. But
Yeah, that's a great way to frame it too. It is buyer beware. And I say that for providers, for healthcare providers, much less for patients. We have to look critically at the studies. I think that the pharmaceutical industry has certainly been a blessing, have brought life-saving, life-altering treatments to market. And again, as you and I have discussed, I'm not a healthcare economist, so I shouldn't wade too deep in these waters. But I think without a solid benefit for the investors or profit motive, a lot of these things would never have happened. But they do have a different incentive structure at the end of the day. I'm not saying they are, not at all worried about patient outcomes or what have you. But when we look at studies, one of the things that we're going to look at is who sponsored the study. If it's a NIH or government-sponsored study, we're good. If it's a well-done study, if it's a study that's sponsored,
I used to believe that until I was been in government for 20 years. Yeah, well, now it is.
Yeah.
The more you get under the hood, the more you go, oh my goodness, yeah, this was presented as gospel until you do a little digging. So,
Yeah.
Anyway,
Well, it's important to, as they say, to be a critical appraiser of the literature. To look at the methodology, to look at the patients that they enrolled. Are these patients, did they screen a lot of patients and a lot of them didn't end up? Did they have a lot of patients lost to follow-up? So, I probably shouldn't go too deep in the stats and how that's done. But your point is a very good one. We have to, as well as Ronald Reagan would say, we have to trust but verify. And we have to, have a healthy degree of skepticism for any new drug or therapy that comes to market. And again, I know I sound a bit like a broken record, but that's where the conversation with your healthcare provider comes in, because I do worry about the public consumption of healthcare information for two reasons. Number one, they may or may not be at a reputable site. And number two, it may not really apply to them. We've had patients in our practice stop medications because they thought that a certain safety recall applied to theirs and it didn't. That's just one finite example.
so the atorvastatin, I believe, is what you said, versus like a rosuvastatin. How are those?
Pretty similar.
Okay.
Yeah, pretty similar. The potent statins are primarily atorvastatin and rosuvastatin, simvastatin to a little bit of a lesser degree. There are now, 7, 8 statins on the market. What that allows us to do is sometimes if a patient has a muscle complaint or something with a statin, I'll switch them to something else. Now, there are non-statin therapies that have come along that have helped reduce cholesterol and improve outcomes as well.
Citrus bergamot, is that something that's a supplement that's recently hit, and it's
The supplements, I actually looked into this again before today just to make sure nothing has come to light. The data backing up supplements is very, very limited. I think there are, and I'm blanking on the name. There are some natural supplements that may lower LDL by about 10%. I think they're plant-based. I'm gonna botch it if I try to remember the compound. So there are some things that at the margins provide a little bit of benefit, but I tell my patients that natural doesn't necessarily mean good. It can be, but it also means that you're getting a supplement which is not well regulated.
and it's really not natural because it's not the plant. It's not the Amish grabbing the tomato off the vine and eating it. It's put together, somewhat synthesized in some fashion.
Yes, I say if you really are into natural and you want natural is your diet and your exercise. It's not something you go buy in a bottle because someone hawked that on social media yesterday.
Yeah.
The supplement industry is, we talk about big pharma, but I think there should be more attention on the supplement industry. I think it's now up to a 1.5 trillion. Oh, wow. I hope I'm not off in the order of magnitude in terms of market cap on that, but it's big. It's big, big, big. It is regulated as a food substance, not as a drug. Again, not an expert here. I want to say they have to just show that it's safe, but they don't have to necessarily show efficacy the same way you do if you bring a drug to market. So
with that, there's all of those items make, as you mentioned earlier, buyer beware. you got to look at all these items as an individual that is trying to improve. So now, as we're trying to improve, and let me know if you have to.
No, I'm just gonna set this to stun instead.
I don't want to make it.
No, we're good.
Time. I know you.
Oh, no.
And you being here and here are to give your time and your expertise. It's fantastic. So with that, you're now. Everybody's got to be aware, and we should care about ourselves.
Yeah.
And so now with that, you now have the Heart Attack Prevention Coalition, where you're trying to help educate folks how they can prevent. Is that mostly to providers, or is that mostly to?
So it is. Some of our work emphasizes prevention, but the Virginia Heart Attack Coalition is really focused more on acute cardiac care.
Okay.
Now, to your point, we are really about quality of care. So at the tail end of that, I talked about the patient coming with a heart attack. For instance, the tail end of that is, say, cardiac rehab. We're big advocates of that. So, but the Virginia Heart Attack Coalition, if this is an okay time, I'll kind of
Wherever.
go into that a bit, because it's been an amazing
Because
story.
you were one of the co-founders and the director, and that's
It's
your baby.
It's been a great thing, I think, for the Commonwealth, and just tremendous people that have helped us put this team together. So, kind of a brief history lesson. I was able to serve as the Door to Balloon chairman for the state of Virginia back in 2005, and started to get a sense that heart attack care was very uneven across the Commonwealth. By that point, if you had your heart attack outside the doors of Lynchburg General or Norfolk and Nova Fairfax, I don't want to leave anybody out, Carilion, Charlottesville, all the rest, you're outside of a major cath lab, angioplasty center, you were going to do pretty well. If you were in far southwest Virginia, if you were in an underserved urban area, if you were in an area without pre-hospital 12 leads, EKGs, as we discussed, your outcomes were much worse. So,
So this is now we're done with prevention. You've had a heart attack. Now what are we doing?
So you are showing up now with your heart attack, and say you're in Bath County or Petersburg or Fairfax or what have you, you're calling 911, or you're driving yourself to the emergency department. What happens next? We looked at, that was our general impression when we began to organize the state, and also pulled data from the Department of Health, and realized that where you lived had a big impact on whether you lived. And for us, that just didn't seem right. It didn't seem fair or just or ethical that a patient that happens to live in a rural county was not going to have the same level of care or hope for the same outcome. So I started to reach out to some folks across the state, like-minded individuals. But the real epiphany, the real aha moment came at a meeting. I was sitting there at the Homestead, American College of Cardiology meeting, and I was listening to a presentation from Dr. Chris Granger from Duke University. And North Carolina had gone ahead. They actually had gotten a grant from Anthem and had gone ahead and used that money to start a statewide heart attack program called the RACE Project. And it was that weird moment where I'm suddenly struck by, what is this? What's going on? We need to do this. We don't have a choice. And so I'm remembering I'm driving back from the meeting the next day, and Nancy was like, you did what? She says, how much did you drink last night? I'm like, I didn't drink at all. I just had this crazy idea. And I think she realized at that point, and I realized, that what we were about to start was going to not only change me professionally, but hopefully, change the status of cardiovascular care in Virginia. So what happened from there is I teamed up with my co-founder, Dr. Mike Contos from VCU, and we set a goal of improving access to what we call rapid heart attack or rapid reperfusion therapy. We wanted all members, all the citizens of Virginia to have access to the same care that they would get at any state-of-the-art facility, and thereby improve survival, outcomes, quality of life, and all the things that come with it. We basically constructed this edifice, if you will, on a foundation of three different things. The first is EMS engagement. We knew that our EMS providers, they were our shock troops, they were our Marines, the first ones to kind of walk in the living room and start the whole process. We also realized they were under-resourced. People were not advocating for them. We knew what they were capable of if we got them the right training and equipment. The next was regionalization. Mike and I still had our day jobs. We couldn't be everywhere at once, but we broke the state up into 6 separate regions based loosely on the MS Council districts, and we mentored or helped create a regional leadership team. Kind of a team of teams, which, just as a quick aside, a book I'll plug. General Stanley McChrystal, who was head of forces in Iraq and Afghanistan, wrote a book called Team of Teams, how you bring people from across an area. It was basically how they leveraged multiple military teams to defeat al-Qaeda in Iraq. It's a fascinating story in and of itself, but very applicable to healthcare. A lot of people are reading it now. So how we cobbled together our team of teams. And then the third pillar, or strategic pillar, was data. We didn't want this to be a lot of talk, sort of a kumbaya thing. We knew at the end of the day that any quality improvement effort worth anything had to show results. And what we were able to show after several years or longer was that the time it took to get that patient to an open artery dropped from about 95 minutes down to 70 minutes. And that's a measurable increase in mortality. That 25 minutes doesn't sound like a lot, but the data's shown that people are much more likely to survive, go back to work, be up and around playing with the grandkids a year later, that sort of thing. So we continue to work to this day. I mentioned one other project we had. We helped get EKG equipment on almost every ambulance in the state of Virginia. And we've also worked with other organizations, cardiac arrest, CPR, cardiogenic shock, different conditions that are associated with that. So 17 years in, that's the Virginia Heart Attack Coalition. It's going strong. We just had our state meeting in Richmond last week, and it's been tremendously gratifying.
So the defibrillators, they're like, I used to never see them as a kid.
Yeah.
Now it's like, I'm at church, a small church, and there's got one there. And so that's, I guess, something that you're talking about as well.
Yes, we have, I work separately with an organization called the Compress and Shock Foundation out of Roanoke. And what they endeavor to do is teach people CPR and AED use, and they also work to getting AEDs into churches, other public places. Just a word about that. We talked a lot about heart attacks, but something very akin to that or can occur in the setting of a heart attack is cardiac arrest. And it turns out that if you suffer a cardiac arrest, you drop in the basketball court, you're shopping at Walmart, you go down, your chance of surviving to the hospital or surviving to hospital discharge is about 1 out of 10. If CPR is instituted and or an AED, that goes up to 4 out of 10. Now, we'd like it to be 10 out of 10, but it's still a malignant, life-threatening condition. But I think a lot of the improvements that we're going to see in the future are going to come from everybody knowing CPR and having access to an AED.
Well, as a kid, I know we had to do CPR training.
Yeah.
And like in high school, for some reason I remember I did. Maybe it was when I was a lifeguard or something, but everybody had to do, I thought like everybody had to do CPR. Now it's been kind of put to the side.
Yeah, I should know this. I want to say there was legislation after a young girl passed away. I can't remember the name of it, instituting CPR education in the public schools, but I don't know the status of that off the top of my head. I don't know.
It does seem like one event makes legislation because, rather than saying, hey, let's do this. This is a good thing. Let's be educated. Let's eat well. Let's exercise. Let's do stuff well. I don't know what's happened in society that you have to have some kind of tragic event.
Yeah.
So you mentioned before about the legislature, or not the legislation, but our society that sues everybody.
Yeah.
With your prescriptions and whatnot, is that helpful to not get sued, or is that is a preventative from that, or is that?
Yeah, it's unfortunate because I think that, clearly we're a litigious society.
Everything.
And
You spill coffee on yourself at McDonald's, which is hot, and they get sued.
right. Right. And there are different incentives there. I think that, and I don't have any easy solutions for that. What we teach and what they taught us is, I think that the more of a discussion you have with the patient, the more informed they are before they make those choices, I think the better off you'll be. Is that a panacea? No. There are always going to be, the human body is mysterious and it's unpredictable, and we all fall short, and so we're humans first of all, and so we make mistakes, however well intentioned. I will lament the fact that although I do think there are cases where patients need compensation and advocacy, and again, another area that I won't get into because I'm a simple cardiologist, but I do think that we, in our quality improvement efforts, that brings us actually to a really good point in terms of how we approach quality. Say we're in the Virginia Heart Attack Coalition, we're going to go visit a hospital that has really slow heart attack treatment times. The best way to approach that when you're building that team of teams is to go in and look for opportunities and not point fingers. Now, that sounds a little bit sort of, again, a little kumbaya, but it's true. Most 99+% of healthcare providers, doctors, nurses, nurse practitioners, they want to do the best job they can. They're human. They may not have, we may have something to help them with in terms of education, in terms of system design. But we always say we look for challenges and opportunities. We don't look to assign blame, because people will close down. If you go in and you say, boy, you guys, what are you doing? You're a bunch of idiots. Your times are so slow. They're going to shut right down. And again, most people in good faith want to get better. And that's been our tack. That's been how we've approached some of these challenges in care.
Like in those the rural counties, I mean, people intentionally are in a rural county.
Yeah.
So that means that you have a volunteer rescue squad, a volunteer fire department. You now have maybe access to 911 because of digitization, but you recognize that you're not going to have. So that's just, so I appreciate your lofty goal, but that seems like an extremely uphill challenge.
It really is. And the percentage of people that live within an hour to 2 hours of a cath lab, what we call a PCI center, forget the exact number, but it's not 50%. I mean, it's probably less than that. If you look at a map of the United States and you look at the placement of different hospitals and cath lab centers, there are big chunks of the country where people are 2, 3, 4 hours from ever getting to that cath lab.
And you don't even have to take the country. You don't have to take the Wild West. You can take Virginia. And there's lots of places, not even far from here, that it takes you quite some time.
And that's some of the emphasis of what we do in terms of system or process improvement. For instance, we have worked on processes where an EMS crew will get that 12-lead EKG, see that it's a heart attack, and call, say, Central 1 and rendezvous in the field. So that's one method. The other is go to the closest hospital and they can give a clot-busting medication, what's called a thrombolytic. We call it drip and ship. They can get that and then transfer to a PCI-capable facility. And by the way, PCI means percutaneous coronary intervention, fancy way of saying what we were talking about, opening with a balloon, placing a stent. So there are ways. The challenges will never be, to some degree, they're always going to be there. But again, it comes down to how do you work as a team and how do you configure that process to try to overcome some of those challenges.
And then having the providers that are willing to locate there. I mean, so that's got to be a difficulty.
It is.
The HR component of hiring people that are going to be like,
I mean, rural healthcare and the disparities and the access issues is almost a subject of a whole other podcast. It's really,
but with it, the way you started though, is that those are the ones. Your rural farmers, they don't need it. They're out there eating healthy. They're out working hard, and they're still in their field. So maybe that disparate impact really isn't a disparate impact because of the fact that they really maybe not have need because of their lifestyle.
Yeah, I mean, it depends on the individual, and we're all getting older, and the population is getting older, and we're going to see a rise in cardiovascular disease. I don't know that we've got, certainly there are fiscal constraints and challenges for hospitals as well. Yeah, there's no end to the challenges.
And one thing that is a fiscal challenge, I think, is from a, I know you said you're not talking about the economics of it, but there has been issues. It's, a certificate of need, for example.
Yeah.
So a hospital can expand unless they get a certificate of need from the government. And that the current hospital doesn't want another hospital to come in, and that certificate of need somewhat blocks competition. I don't know. That's a...
Well, I mean, I think you probably know more about CON laws than I do, but I think that it points up the larger issue of turf and competition. And that's one thing VHAC worked very hard to break down. I was at a meeting in Richmond, about 10 years ago, and I had service line directors or VPs of several hospitals that shall go nameless. They ended up being really wonderful contributors to VHAC, but at the time they were really angry at each other. We're all sitting in a room, and one of them just started going off on the other one because his hospital was advertising their door to balloon times, and I thought we weren't going to do that, and blah, blah, blah. So I finally stood up and said, guys, it's about patient care, not market share. And the room kind of went uncomfortably quiet. And my buddy was like, hey, that's our new slogan, right there. Patient care, not market share. So, but in time, we were able to kind of co-opt that competitiveness, get people to sort of play together in the sandbox. And
put those times in there because that is helping the patient care.
Yeah.
I mean, yours is 95 minutes. Well, guess what? Mine's 38 minutes.
There was a healthy, what do they call that? Co-opetition, like competition and cooperation. So there's always that. But I think that,
because if that's the ultimate goal of helping the patient, that is helpful.
that's what it is. It is. And it's patient-centered. And we stress that over and over again. And sometimes I'll tell people that, because I've been around healthcare long enough, I know that we've seen things come and go. And there's a tendency maybe to be a little jaded or cynical. And I'll say, I know, patient, that's what everybody says, blah, blah, blah. But I will say that when you walk into systems or hospitals where the patient's not at the center, you can tell pretty quickly. And we try to stress in VHAC, certainly even in our acute MI system, et cetera, if you can keep the patient at the center, you can keep people moving in the same direction.
Nice.
It really, I think, takes a lot of the steam out of those squabbles and that.
Back to your team continuums concept, it sounds like. I mean, you're getting people together from all teams, and we're pulling together for a common goal.
Yes.
Yeah. So how has AI changed the field of cardiology?
It's already changing, and it's going to be pretty momentous. I already have worked with, for instance, I've already worked with an application from a company out of Europe called PM Cardio, and the app is called Queen of Hearts. And basically what they did was they took 20,000 EKGs and taught, and I apologize to your AI expert listeners, whether it's a large language or neural network or what have you, whatever voodoo they used, they basically taught this AI model on 20,000 EKGs to read a heart attack.
Wow.
And it turns out that this app is better than an experienced cardiologist or an ER physician. Surprise, surprise. It's pattern recognition. It's exactly already what AI is capable of doing. I think something like that is going to really revolutionize care, especially pre-hospital care. It takes a long time to become a good EKG reader. It's hard to get out and teach, brand new docs and EMS providers and everybody else how to pick out the subtleties, especially when they're doing 10 other things in the heat of the moment. So to have an app to be able to read that accurately is already a huge step. And that's not even to say all the other areas of medicine. I think it's going to be applied to reading cardiac studies like ultrasounds, echocardiograms, decision support. Already there are AI apps that can pull together the literature and answer a clinical question pretty quickly. There you have to be a little careful because we know that, I think the AI people call it hallucinating. We know that AI can sometimes just come up with crazy stuff. So you still have to have a trained eye when you look at it. But
You need intelligence that can oversee the artificial
exactly, right. At least pulls together, okay, this is the general gist. Here are my references. I can go look these up. But we're very excited about it. I think like everything else in industry and in healthcare, I think we're all just waiting, holding our breath to see what, if you,
Sounds like with the coalition, like especially some rural county, they can adopt something or utilize.
yes.
You know,
Yeah, I think that's going to be a game changer. Get those in the hands of our EMS providers, our ER physicians, urgent care facilities. I think we'll miss a lot fewer heart attacks.
see, years ago, another thing with our EMS providers in the city, the 911 operator. So before EMS got there, somebody's calling and saying, "Hey, here's the problems that we're having." We then, which I pushed for, and we got a manual where the 911 operator could flip through, or obviously computerized, and say, "Oh, you're having these symptoms. What about this? Maybe this would be a good."
Yeah.
And that helped now. Something that happened instantly, and it took 15 minutes or 10 minutes for the EMS to be at the door. They could at least be helping with the other person on the
You
telephone.
even wonder, and this sounds a little bit science fiction-y, but you even wonder if there are going to be AI algorithms or programs that can detect based on the patient's voice, cadence, breathing patterns. I mean, I've heard things that basically analyzing inputs like that will already give some clues as to the respiratory status or what's going on. So it's a brave new world.
Are you using much of that with the either the cath lab, et cetera, or your heart attack coalition?
Not yet. I think that the most immediate application will be the one I mentioned, the Queen of Hearts. I think that will be important. It's already helping with documentation, with a burden of documentation for insurance companies and everybody else. It's difficult to get those notes done in time. Already providers are using those to help construct the notes. We're using it pretty regularly, I think, for accessing knowledge and studies, things like that. But talk to me in 5 years. It may be radically different.
Probably in about 2 weeks. It may be
radically
different.
That's right. Absolutely.
Well, Dr. Pete O'Brien, we so great appreciate you. Yeah, and it hasn't been just a recent study. You've cared about it as an avid athlete, as you've trained your children that are athletes now. You've helped coach teams, not just to be performing athletically, but to be healthy. And thank you for all you've done for Central Virginia and for Virginia. So thank you.